Hi, everyone. This debate is centered on the alternative models of treatment for individuals with autism spectrum disorders, or ASD. My name is Lauren, and I'll be arguing for the applied behavior analysis as a treatment for individuals with ASD. Susan will be arguing for the ABA side as well, using supporting research. Danielle will be arguing in favor of the medical model of treatment for individuals with ASD and will present research-based arguments for the treatment and against ABA. Ashley will be presenting information for sensory integration therapy as a treatment for ASD and arguing against ABA. First, research supporting ABA will be presented, followed by sensory integration, and medical model will be last. Following each treatment, there will be attacking points from the other sides with an opportunity for each debate participant to rebut their attacks. The objectives of this presentation: define autism and review treatment options for ASD, describe applied behavior analysis and discuss research supporting ABA as a treatment for ASD, explain the medical model as a treatment for ASD and review the research that supports the model, define sensory integration theory and examine research supporting it, and then discuss the ethical issues involved when considering treatment options. According to the CDC, applied behavior analysis is a notable and widely accepted treatment for individuals with autism spectrum disorders. ABA is a treatment that seeks to discover the environmental variables that reliably influence socially significant behavior and develop practical behavior change systems to address those discoveries. Skill building and developing positive behaviors are a main focus of ABA, not just simply decreasing negative or challenging behavior. As stated by Cooper, Heward, and Heron, what sets ABA apart from other treatments is their focus on goals and methods such as objective description, quantification, and controlled experimentation. Bear, Wolf, and Risley recommended that ABA techniques be applied, behavioral, analytic, technological, conceptually systematic, effective, and capable of generalized outcomes. When an individual is receiving ABA services, their data is being tracked and reported.
The medical model of autism is a subset of the medical model for disabilities. The primary goal of this model is the prevention or curing of autism. The advocates for the medical model believe that autism decreases an individual and their family's quality of life. Medication administered to alleviate severe behaviors such as SIB and aggression have impacted the lives of those affected by autism for the better. Medications, which are FDA approved to be used in individuals with autism, irritability, sleep problems, and aggression. Typically, these medications have proven to reduce severe behaviors to a degree where individuals on the spectrum are able to participate in the community with fewer safety concerns. Funding has been directed towards the research and understanding of what causes autism. In 2016, Autism Speaks raised $12.7 million with studies such as Missing, which is the largest genomic database whose philosophy is to promote and enable open science research to lead to a better understanding of autism. Their current undertaking will establish a database with the DNA from 10,000 families affected by autism, along with clinical medication trials that, if successful, will eliminate the symptoms of autism. The collection of DNA will allow researchers to identify subtypes of autism and furthermore create individualized treatment plans based on categorical data. In addition to the Autism Speaks initiative, former President Barack Obama signed the 21st Century Cures Act, which allotted $5 billion in federal funding over the next 10 years to support the research of brain, an initiative that will lead to deeper knowledge of the human brain, which will seek information on the lifestyles, environment, and biology of Americans in order to improve treatments for disabilities.
The American Journal of Occupational Therapy, or AJOT, sensory integration therapy as a program of intervention involving meaningful therapeutic activities characterized by enhanced sensation, tactile, vestibular, and proprioceptive, active participation, and adaptive interaction. Occupational therapy is a common intervention for those diagnosed with autism spectrum disorder, or ASD. And it's reported by the AJOT that 82% of OTs use sensory integration therapy to increase the independence of clients with autism spectrum disorder and sensory processing disorder, a common comorbidity of ASD. This intervention was developed by occupational therapist Jean Ayers in the 1960s and is used to treat ASD, SPD, ADHD, and ADD. Clients diagnosed with ASD and SPD have difficulty regulating internal and external stimuli, or use self-stimulation to compensate for their body's hyper reaction to sensory input. Sensory integration theory, or SIT, is implemented based on the understanding that interferences in neurological processing and integration of sensory information disrupt the construction of purposeful behaviors. Through SIT, the nervous system sensory modulation and self-regulation abilities improve, resulting in an increased ability to focus on behavior, attention, social interactions, academic skills, and independence. A sensory integration session would include a variety of graded activities that address the proprioceptive, tactile, vestibular, olfactory, gustatory, and visual senses to increase adaptive responses by the patient. These adaptive responses eventually increase the client's functionality in the presence of various stimuli. Sensory integration therapy combines the therapist's use of physiological processes while teaching a patient adaptive and compensatory responses to over and under stimulation.
Okay, ABA is the only evidence-based treatment. As Lauren stated earlier, ABA is a scientific process by which interventions are carried out based on principles of behavior in order to change socially significant behaviors. The key word here is scientific, meaning that ABA is a method that relies heavily on data collection in order to show scientifically that its interventions are what causes the behavior change. In other words, because ABA makes use of data, it can show proof of intervention effectiveness, whereas many other methods cannot. Often, research studies evaluating effects of ABA methods take the data one step further by not only gathering data on the behavior of the participants, but also collecting treatment integrity data as well as inter-observer agreement data. Treatment integrity means to what extent the intervention was implemented as intended. In other words, data is taken on how well the teacher or parent followed the prescribed intervention. Inter-observer agreement is calculated as the percentage of trials that two separate observers were in agreement with scoring the target behaviors. For example, if the frequency of hand raising was observed for a 10-minute period, and the primary observer observed 10 instances of hand raising while the secondary observer scored only 9, we would say that the inter-observer agreement is 90%. When treatment methods are demonstrated to be effective in the research, we consider them evidence-based practices, or EBPs. ABA is the only evidence-based practice as a method for treating autism spectrum disorders to date. This means that there's an abundance of research studies and published articles that demonstrated results in support of the use of ABA and the principles of ABA as a method for facilitating behavior change. The Journal of Applied Behavioral Analysis was first published almost 50 years ago in 1968. Since then, thousands of studies have been published supporting ABA. Not only does the literature support ABA, but federal laws have been enacted supporting evidence-based practices in educational settings. The Individuals with Disabilities Act, as well as the No Child Left Behind, both reference the fact that treatments need to be based on the best available research. The Behavior Analysis Certification Board, the BACB, requires that board-certified behavior analysts follow their professional and ethical compliance code, which includes a behavior analyst's duty to rely on scientific knowledge when making behavior analytic decisions. In fact, this is the very first code.
In a 2010 alternating treatments design study conducted by Devlin, Healy, Leader, and Hughes, sensory integration therapy and behavioral intervention techniques were compared to determine their impacts on the rates of challenging behavior in children with ASD. This chart shows the results of that study. The results indicated behavioral interventions were most effective in reducing challenging behaviors in the participants. The best treatment phase, where behavior interventions were implemented alone, demonstrate further reductions in behavior.
There are many articles and studies supporting many different treatments for autism. How can we expect parents and new professionals in the field to weed through hundreds of articles to determine which treatments are most effective? Well, fortunately, we don't have to, because there are several projects and meta-analyses available that have compiled hundreds of studies supporting different treatments in order to evaluate which treatments are most effective. Evidence-based practice and autism in the schools is a project conducted by the National Autism Center, who compiled an expert panel to determine the most effective treatments based on available research. The findings showed that behavioral packages were an established treatment. The National Standards Project Phase 2 is another even more extensive review of 389 studies by an expert panel who devised a rating scale to determine which treatments were established, emerging, and unestablished. Behavior interventions are the largest category of established interventions, with over 150 articles included. Additionally, interventions such as modeling, pivotal response training, and schedule usage are all methods used within ABA and are also considered established treatments according to Phase 2 of the National Standards Project. Sensory intervention packages, however, were not even considered to be emerging treatments, but rather they were unestablished, meaning there is little, if any, evidence to support their effectiveness. The medical model of treatment was not even considered in this project. Evidence-based practice for children, youth, and young adults with autism spectrum disorder is another study conducted by Wang et al. In 2015 that found similar results. They compiled over 450 studies and analyzed the results in order to determine which interventions qualified as evidence-based. The majority of the studies considered as being evidence-based implemented techniques utilized within ABA. These include techniques such as prompting, discrete trial teaching, modeling, differential reinforcement, just to name a few.
While most published research supports ABA, studies that show negative or inconclusive results are often not published, therefore skewing the results. This and a few other points are drawbacks to ABA. Of the published research supporting ABA, much of it uses small samples with limited randomized clinical trials. Many of the studies conducted have only 2 to 4 participants. Therefore, results should be interpreted skeptically, because this doesn't tell us a lot about how a treatment will work for the autism community as a whole. ABA also does not directly address the needs of those diagnosed with sensory processing disorder, a common comorbidity of ASD. Progress can be seen and is noted in other disciplines as well, but their form of documentation and measurement may not use the same formalized data collection processes as ABA. There has been some controversy surrounding the effectiveness of sensory integration therapy as a best practice for occupational therapists and as an evidence-based practices are emphasized. As a result, 27 studies were systematically reviewed to determine the effectiveness of sensory integration therapy as an evidence-based treatment in a 2010 American Journal of Occupational Therapy article, according to May, Benson, and Coomer. The analysis found that sensory integration therapy outcomes were better than outcomes associated with no interventions in over 50% of reviewed studies. Recent studies have shown positive trends supporting the effectiveness of the sensory integration approach, especially when measuring goals customized for the client. Occupational therapists have reported a wide range of benefits of implementing sensory integration therapy into their therapy sessions. 3 of the main benefits reported are enhanced ability to focus on relevant materials in educational, therapeutic, and social environments, reduction in the rate of apparent behaviors such as self-injury, and generalized improvements in nervous system functioning, reflected in gains in higher cognitive activity, such as language and reading. Furthermore, in an article entitled Systematic Review of the Research Evidence Examining the Effectiveness of Interventions Using a Sensory Integrative Approach for Children, that was published in the American Journal of Occupational Therapy, the SI approach, or sensory integration approach, may result in positive outcomes in sensory motor skills and motor planning, socialization, attention, and behavioral regulation, reading-related skills, participation in active play, and achievement of individualized goals. Lastly, in a 2013 study published in the American Journal of Occupational Therapy, found that a group of 40 children diagnosed with ASD showed increased self-regulation techniques after sensory integration interventions.
While SIT is a widely used intervention by occupational therapists to treat ASD, the benefits are largely anecdotal without concrete evidence-based research. For example, a 2012 review of 25 studies entitled Sensory Integration Therapy for Autism Spectrum Disorders, a systematic review, found only 3 studies showing the effectiveness of SIT. 8 studies found mixed results, and 14 showed no correlation to SIT and functional progress. Furthermore, an article in the Journal of Autism and Developmental Disorders comparing behavior interventions with SIT found there is no consistent agreement within current literature on the effectiveness of SIT for autism and no scientific basis for the use of SIT. The study also concluded that participants showed better results with the use of behavioral intervention when compared to sensory integration interventions.
While researchers continue to zero in on an explanation for the cause of autism, which genetic factors and environmental factors are most fruitful. Research has shown genetic and environmental risk factors may be associated to autism of contention in twin studies. For instance, twins who come from the same egg and therefore have the identical DNA, both having autism. Or if one has autism, then it is highly likely that the other has traits of autism. Twins from different eggs who do not share identical DNA are less likely to have autism traits. Twin studies have also provided evidence for environmental factors. Of monozygotic twins, only one has autism. In cases of ASD, in monozygotic twins, the severity and behavioral traits are different between siblings, and in 30% of cases of ASD, twins will have autism, while the other will have traits of autism. Monos share identical DNA, which would not explain these differences. Studies of the immediate family members of individuals with ASD has a higher chance of autism or behavioral traits of autism as opposed to families with no history of autism. Broader autism phenotype, or for short, BAP, describes individuals who show non-significant or partial behavioral traits of a clinical diagnosis of autism. Those who fall within the BAP criteria are known as multiplex families, which occurrence shows significant results of a genetic linkage to autism. isolated incidents of ASD families, or to as sporadic ASD. It is also often ASD is caused by environmental factors. The current knowledge of potential environmental risk factors is broad. Possible factors that can contribute to autism. More research needs to be conducted. Known or suspected risk factors that play a role in prenatal, perinatal, and postnatal these potential factors. Quality of life for individuals on the spectrum, along with their families, is an area most afflicted. Individuals with severe behavioral issues, such as self-injury, aggression, and disruption, will have a restricted lifestyle in the community, as well as home setting. Friends and extended family members may also experience a reduced quality of life in the form of shortened time in the community, with friends or family, or in more severe cases, an inability to leave their immediate environment. As a necessary tool to aid in a less more purposeful quality of life for all members of the afflicted party. As mentioned prior, is most often prescribed to more severe cases to reduce stigmatic and dangerous behaviors. Studies have shown that comorbid physical, medical, and mental health problems are common in individuals with autism. To determine if the severity of ASD affected the prevalence of a comorbid disorder, it found that tantrum were predicted by autism severity. The author also notes previous studies in which research found a high prevalence of comorbid disorders. For example, in 2006, Lafer and colleagues reported that up to 70% of their sample with ASD had at least one psychiatric disorder. Simonoff and colleagues found that 70% had at least one comorbid disorder and 41% had two or more comorbid disorders in their sample of individuals with ASD. Mental health problems is depression and anxiety in high-functioning individuals. Typically observed individuals can be thought of as maladaptive and will exclude these individuals from society population.
Higher functioning individuals on the autism spectrum have been vocal in their opposition to the medical model for autism. Advocacy groups such as the Autism Rights Movement and Aspies for Freedom have spoken out against the medical model and behavioral interventions used to decrease the stereotypic behaviors of autism, as well as believe that autism is not a disorder, but a variant of human nature that does not need to be cured. The advocates of these groups are comprised of individuals who have autism and also parents of children with autism. Their message is clear. They want society to be accepting of individuals with autism and neurodiversity. Neurodiversity is a concept that neurological differences should be respected rather than seen as impairments that need to be cured. Individuals with higher functioning autism have created networks and communities who want to speak for themselves rather than be spoken for or about by parents and professionals. There are also ethical issues that arise for medications that aim to decrease stereotypic behaviors associated with autism. It is understood that severe behaviors such as self-injurious behaviors and aggression should be intervened upon. But where would it end? In these groups, a child's hand flapping, inappropriate vocalizations, and irregular motor movements are stereotypic behaviors that have been welcomed as quirks and make the individual special, as well as their exceptional skills of focus. Another ethical dilemma pertaining to cures for autism is the abundance of unfounded treatments that are said to cure autism. Just by doing a simple Google search, one can be bombarded with many materials stating that the cure for autism is through fad diets like gluten-free, treatments such as chelation, hyperbaric chelation therapy, hyperbaric oxygen therapy, but none of these are significant, but because there is still more to learn about ASD, people may sway down uninformed paths searching for a cure. Okay, so ethical considerations. Code 1.01 in the BACB's Ethical and Compliance Code states that behavior analysts rely on professionally derived knowledge based on science and behavior analysis when making scientific or professional judgments in human service provision or when engaging in scholarly or professional endeavors. That means we need to focus on evidence-based practices when treating individuals with ASD. In addition, Code 2.09, Treatment and Intervention Efficacy, states that clients have a right to effective treatment, i.e. based on research and literature and adapted to the individual client. Behavior analysts always have the obligation to advocate and educate the client about scientifically supported, most effective treatment procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients and society. Behavior analysts have the responsibility to advocate for the appropriate amount and level of service, provision, and oversight required to meet the defined behavior change program goals. Where more than one scientifically supported treatment has been established, additional factors may be considered in selecting interventions, including but not limited to efficiency and cost effectiveness, risks and side effects to the interventions, client preference, and practitioner experience and training. Behavior analysts review and appraise the effects of any treatments about which they are aware and that might impact the goals of behavior change program and their possible impact on the behavior change program to the extent possible.
While there have been mixed reports regarding the effectiveness of sensory integration therapy, some studies do support the outcomes described by occupational therapists, such as increased independence in social, academic, and living skills. This treatment is widely used by occupational therapists in treating ASD and SPD, and further research should be conducted while continuing to implement this intervention.
Continued research in the area of genetics and environmental factors will lead to the further knowledge of a genesis or cause prevention of aforementioned behaviors that lead to a decreased quality of life.
Okay, final rebuttal and summary of ABA points. ABA has the most research to support its efficacy, as stated earlier, with over thousands of articles supporting ABA techniques and methods. ABA is the most widely used method for treating autism spectrum disorder within school settings. Again, as stated earlier, federal law has mandated that evidence-based practices be used in the schools. ABA therapy is one of the only treatments covered by medical insurance as a treatment for autism spectrum disorder. Other medications are sometimes covered, but typically they're covered due to a comorbidity. Other therapies and models for treating ASD simply lack data to defend their efficacy.
As clinicians, we must understand and be sensitive to the fact that some families may prefer alternative models of treatment due to their cultural or religious beliefs. BCBAs often provide treatment within the child's home, and some families may not be as comfortable with in-home therapy as other families might be. In addition, professional, educational, or personal experiences may influence treatment choice. Some parents, caretakers, or family members may be partial to another model of treatment based on what they do for a living. For example, medical model as a medical professional, or SIT as an occupational therapist, or someone who's familiar with the OT field. Costs and treatment as well as access to resources may also play a role in these choices.
We'd like to address a few additional questions regarding the different models of treatment in ASD. So the first question is, sensory integration is becoming more prevalent as a therapy for individuals with ASD. Have any of you had an experience with other professionals that implemented this therapy? And/or have you ever worked with a parent that wanted their child to have this therapy? If so, how did you handle the situation with this intervention due to it not being an evidence-based treatment? I've actually had experience working with other occupational therapists and occupational therapy assistants implementing sensory integration. I'm a licensed OT assistant, and during my fieldwork experience, I interned in a sensory integration clinic. The clinic included different types of swings, mats, crash pads, climbing walls, and suspended toys. The sessions were structured to address the sensory needs of the clients by slowly increasing their tolerance to sensory input. Over the course of therapy, I did notice differences in the client's response to various activities and sensory input. As I implement ABA treatment now, I keep in mind some points I learned about sensory integration, such as how many clients respond well to calming deep pressure input, although every client is different. This experience, I know that I can't rely solely on these techniques, as there is a lack of evidence supporting its efficacy. I've also worked with clients who requested these services from their OT provider and who wanted to incorporate a brushing program and a sensory diet into our sessions. In the past, I haven't mentioned the intervention's lack of evidence when discussing these topics with parents, but I have mentioned that during our ABA sessions, I'm happy to incorporate not necessarily sensory integration techniques, but a wide variety of activities such as gross motor, fine motor, excitatory and calming types of activities. But I will still, my primary concern approaching treatment is primarily addressing the ABA goals and use of ABA principles.
Okay, the second question that we got was, in order to defend ABA against alternate models, how should a behavior analyst prepare him or herself to debate this topic? Well, I hope it's clear from our debate that the answer is research. The first step in preparation to defend or educate others in ABA is by doing research. As behavior analysts, we need to do thorough research about topics pertaining to our clients in order to best serve them. This includes research that is current within the last few years, as things often change. Through this debate, our group has learned about what models of practice are backed by the best evidence-based research. We've also educated ourselves on all sides of the topic to better understand the pros and cons of the various methodologies.
And the third question is, if you are working with a child in the home and a parent asks you to incorporate some of the sensory integration techniques that the OT uses while you're working with the child, what do you do? What ethical code is compromised in this situation? Well, I had sort of a personal experience with this exact situation in the past, so I'm going to talk about that a little bit. Years ago, I worked with a young boy that had ASD at his home. We did like 30 hours a week of in-home therapy, so it was pretty intense. I was supervised by a BCBA from an in-home ABA therapy agency, and at the beginning of my time working with him, his mother asked if we could incorporate a sensory diet into his sessions to help him with his sensory processing issues, because he definitely had those. So what I did was I approached the BCBA on this issue, and we coordinated with an OT from another department, because this was actually an agency that did home health care, just across the board, all different kinds. So there happened to be an OT that traveled to homes that worked within the same agency. So she wrote a sensory diet for him after completing a few assessments, while I assisted with his behavior during the assessment process. After she'd written the diet, she came out to a session of ours once a week to work with him on sensory needs while I continued to implement behavior support plan techniques. This is sort of like a very unique situation. I would not ever attempt to directly incorporate OT techniques into my own ABA sessions, because that's not within my field of expertise and not a behavior analytic approach. As I did previously, in a situation like this, I would refer to the parents to an OT to discuss sensory related issues. In addition, I'd probably provide a little research regarding SIT versus ABA to address various needs. The ethical code in violation potentially in this situation would be code 4.01, conceptual consistency, which states, behavior analysts design behavior change programs that are conceptually consistent with behavior analytic principles. And that concludes our debate. I hope you guys enjoyed it. For a list of our references, you can check out the discussion board, because we will be posting them there. All right, thank you.